Welcome back to the second part of the discussion regarding nursing care of the woman who requires surgical intervention for um, birth. So, in the first portion of this discussion, we covered the indicators or reasons why a woman may need a scheduled or an emergent cesarean section. And then we moved into routine nursing care provided in the preoperative setting and the intraoperative setting. What I'd like to discuss now with you for a short time is post-surgical care. So again, reiterating that we are caring for a woman who has just undergone abdominal surgery to birth her baby, and all of the things that we've learned about post-operative care would apply here, in addition to these newer concepts of postpartum management. So we would certainly be including in our assessments the assessment of the fundus, that it's firm and returning and involuting to that level of the umbilicus, and that we are also noting its position. Is it midline and below? And we would also be paying close attention to herlokia and those other assessments that we do in the postpartum period. The vital signs, much like you learned in the immediate postpartum period for the vaginal delivery, will be the same for the postoperative client. Those are going to be every 15 minutes, a full set of vital signs with a postpartum assessment, and also a surgical assessment looking at the primary dressings that have been applied and noting any bleeding that's coming through the primary dressings. And we would mark them the same way that you learned in your surgical course, and that is by gently encircling the area with date and time and initials, and noting that and reporting anything that indicates active bleeding below the primary dressing. We would definitely notify the team if that was something that was getting progressive. So the other thing that we want to pay attention to postpartum is what was the blood EBL, the estimated blood loss during the procedure. You remember back in your normal labor and delivery chapter when we talked about a vaginal delivery, we talked about anything greater than 500 was considered a postpartum hemorrhage. In the surgical client, it's anything greater than 1,000 mLs that would be documented as a hemorrhage in that surgical client. The other issues postoperatively, in addition to those surgical checks in the immediate postpartum recovery period, would be the pain control. So we talked a little bit about Duramorph and the effects it has, and really the excellent way that it manages pain for women. Keep in mind that women who are on Duramorph typically don't need any other meds, with the exception of possibly the diphenhydramine for the itching. But they will be transitioned over in many facilities. The protocol might include offering some IV ketorolac, which is a really good, efficient, non-steroidal anti-inflammatory. And then once the Duramorph, either depends on the agency, but outside of that 18 to 24-hour window, then they may transition the mother over to oral opioids or oral analgesics. For facilities that aren't using Duramorph, typically PCA would be the method of management. And again, understanding the principles behind PCAs, you can find that in your pain chapter, and also you should have received that in your surgical lectures from last semester as well. Keep in mind that when we recover somebody who's had spinal anesthesia, we're always assessing return of sensation, the ability for them to start to lift their legs from the mattress and move independently or with assistance in the bed. And those assessments are ongoing until we are confident that they could get up and stand on their own at the side of the bed. But we have to, that's a progressive assessment that's happening. And then the recovery of the client who's received general anesthesia, which is a often administered for one of two reasons. The first would be that it was an emergency and there was no time to administer a spinal anesthetic to do the surgery. So if time is of the essence, then general anesthesia would be the easiest way to get the birth completed. Or for the woman who we just couldn't get spinal access, then that could be an avenue that the team may need to explore. But again, if someone's recovering from general anesthesia, it's assessing the respiratory status, that they're able to lighten up and come out of their the effects of their general anesthesia, and then return of sensation and orientation to person, place, and time, and then any of those other side effects that can sometimes occur, like managing nausea and vomiting, dizziness, things like that. Fluid and electrolyte management and INOs, hydration is important postoperatively in the surgical client, and typically women who have had a cesarean section will have had an indwelling Foley catheter placed for the procedure, and depending again on agency policy, that can be removed right after the procedure is a way that some agencies are doing it and some are doing it now in less than 12. Again, paying close attention to those CAUTIs, the catheter-associated UTI rates, that we do need to be mindful of. And then infection control, obviously, is keeping the incision clean, dry, and intact. When the primary dressing does indeed come down, this client will, in addition to normal postpartum management, need to have her surgical site assessed every shift, and that should be looking for things like odor, the appearance of erythema, edema, any kind of ecchymosis, drainage, approximation, closure. Typically for cesarean section, the two most common closures that you will see underneath that primary dressing would be either wound closure by staples or by a skin adhesive, like a Dermabond would be an example of that. So that's all dependent on the surgeon and what they choose to do closure. That is it for the cesarean birth, normal, and we'll talk more about cesareans when we get into complicated deliveries later in the semester. Have a great day.